to see it as they log in. So today we have a really good set of images for all of us to analyze, and I am really excited about this. The majority, all of them were actually sent to me from Mexico, and I'll give proper credit to each one of the. Okay, now they're asking me if this is the proper link. They're killing me here. Sorry. Alrighty. So disclosures, we discuss particulars of ventilator modes. There's no endorsement of any particular mode or manufacturer or company. Whatever we say, it's our opinion, and it does not represent Cleveland Clinic's. I do, and Rob gets royalties, and we have some conflicts of interest, but none of them related what we're presenting today, but just for you to be aware. And so this is a recorded session, so just keep your microphone muted and use the chat function. It's really useful for us to see who's here and who's not here. And if you want to comment, just use it. And or if you want to unmute your, I'm not opposed to you commenting as much as you want. So now that we're talking about synchrony, the key is to recognize trigger as the start of mechanical inspiration and cycle as the end of mechanical inspiration. And this is something that in the literature has been actually confused, and sometimes they use a word for the other. Just I want to be sure that as we're talking about this, you know, whenever I say trigger, I refer to the start of the mechanical inspiration, and when I talk about cycle, is the end of it. Let's keep going. In terms of the patient signal, I want you to recognize that now we have the ability at the bedside to use the electrical activity of the diaphragm with NAVA, so we can see the actual signal of how the diaphragm is activating. And this is a signal that is very complex, but thanks to that technology, it has become relatively simple and a waveform that it's interpretable by our eyes. And that results in a contraction of the muscle that actually decreases the esophageal pressure and it drops it below baseline. And then the maximum contraction is reached, and then it starts relaxing. And as it starts relaxing, the Pmus returns to baseline. And then there's the airway pressure, which happens after the esophageal pressure goes down, and that will cause the airway pressure to move up. And so just remember that the patient is the reference signal, and if you have the neural signal, that will become the truth. If you don't have the neural signal, then it becomes the muscle, and if you don't have the muscle, then it becomes the airway pressure signal, the interpretations that we have been doing, and that what we usually do on SEVA VentRounds. So here's the first example, and again, this is courtesy from Dr. Carmen Hernandez Cardenas, and she's at the Cuidados Intensivos Respiratorios, the respiratory care unit of the National Institute of Respiratory Diseases in Mexico. It's pretty famous, the INER, and so I really appreciate them sharing images with us for us to review today, because they are really nice. So let's start with this, and in the chat, as you read it, and I have cheated a little bit by blocking a signal down here, but I want you to train your eyes to see what is happening on the waveforms, and then we'll show you the truth. And so, as usual, we start by defining what is the tag, then what is the load, and then what PV discordance do you see? So trigger, inspiration, cycle, expiration. In this case, there's no volume waveform, so we're skipping that. So for the fellows online, RTs, just share with us by entering on the chat what's the tag, what is the load, and what's the PV discordance. And other than what I covered here, that's the only thing that I'm blocking from sight for you. I'll give you a couple of minutes. I know that everybody's settling after this change of location that essentially it's like if they have changed the meeting room for us. Alrighty. Well, let's get started on this. So this is the tag for this mode is a little bit tricky. And it says here APB CMB, and obviously every manufacturer has decided to invent their own nomenclature, and so it confuses the everybody. So we have the standardized taxonomy. In this case, the pressure is being controlled, and we know that because if we look at the flow is each one of them was different. And actually, you can see here a breath in which the pressure seems to be controlled and it decays exponentially. So I see everybody's putting in, and they recognize that this was a pressure control breath, and so we'll put it there. And then after the pressure control breath, it comes the breath sequence. And every single breath that we see here, this ventilator tells you when the breath has been triggered by the patient, and you can see this little triangle that is occurring here that's telling us that this breath was triggered by the machine. However, sorry, by the patient. However, this one is triggered by the machine, this one is triggered by the machine. And then the next question is who cycles it? So if this is machine triggered, this is a mandatory breath, this is a mandatory breath too. And so is this cycled by the machine? And there's a clue here. And the clue is, if you notice, the flow actually crosses baseline right here by where number 6 is. It crosses baseline, which tells you that the patient is actually now exhaling. And you can see how the flow goes below baseline. And meaning that if the machine is still delivering pressure, so under that circumstance, this has to be a machine cycled breath. And so this becomes, each one of these breaths is mandatory. So just by what we're seeing here, I can make the conclusion that it's CMB, which luckily matches the CMB that says here. So all breaths are mandatory. And then the targeting scheme is hard for you to see it here because each breath looks exactly the same. This one there's no Pmus during it. In these ones, there's evidence of Pmus, either inspiratory or expiratory Pmus. And so under those circumstances, it's hard to find the targeting scheme. But if you go to the Vent Mode app in your phone, you will find that this mode, which is adaptive pressure ventilation CMB, is actually an adaptive targeting scheme in which the ventilator will target a tidal volume that we set and adjust the pressure to achieve that. In terms of the load, all of you recognize Pmus. There is evidence of Pmus here, everything that it's above what it would be expected. So this exponential decay is Pmus. So during inspiration, there's Pmus. However, I would say just remember that whenever you have Pmus, you have several breaths here. And if you look at this breath over here, this breath has no Pmus, right? It's beautiful decay, exponential decay. And it goes back to baseline in less than a second. So it seems this is the marker for 1 second. So within 1 second, it goes to baseline, which tells you that this is most likely an elastic load. And then I can also look during the expiration. During expiration, it also looks like there is a exponential decay very nicely, and it also seems to be within a second. So I would say that the load is a presence of Pmus during inspiration, but underlying there is an elastic load. So in terms of the PV discordance, I see a good amount of discussion going on the chat. I love it. This is like mini Twitter. In terms of what type of problem is this one. So let's take a look. So in the first one, the breath is triggered by the machine. We agree with that. And we know that because there is no marker from the ventilator and we don't see any deflections on the waveform on flow or pressure, which tells me that this is mandatory, but I see evidence of Pmus afterwards. So when you have mandatory followed by Pmus, this becomes early trigger immediately. Okay, that's this and this equals early trigger. In the next one, you actually have the marker. So you have the man that you know that this is actually a patient trigger breath because the machine is telling you that it was triggered by pressure, and then you have evidence of Pmus. So this one actually becomes it's normally triggered. So this one is normal, and then the last one is just a passive breath where there is no evidence of Pmus. So this was a mandatory breath and completely passive. So you have three examples of triggering here: completely passive patient, a patient that has evidence of Pmus during the whole breath, and this one that has early triggering. And so that's the trigger. And then in terms of inspiration, I saw that many of you put or talked a little bit about work shifting. And yes, there's I mean, whenever there's Pmus in pressure control, there's going to be some work shifting, but it's there, but it's not probably clinically relevant. So if you put work shifting and it's mild, that would be appropriate or moderate. It's hard to quantify. Actually, this is an area that needs to be developed further into how to quantify the amount of work that a patient, what a patient does. And then in terms of cycle, the first breath actually cycles pretty close. You can see this little deflection right there. In that particular area, I'll make it big for you to see. That little deflection there tells me that the patient, and you can see how the pressure went up, that the pressure was exhaling and against the ventilator still, or relaxing the muscles with the ventilator still delivering pressure. And in this one, it's definitely a late cycle, meaning the ventilator cycle later than the patient. The patient was ending the breath, and the machine, it has a late cycle here. So there's two late cycles in the first breath and the second breath. The other one is passive. Nobody complains. And then during expiration, there's no work. So it's essentially normal. So let's take a look. And I saw that there was some discussion regarding is this the early trigger or not. So the signal that we have down here is really good, because you're gonna see this is why the truth is so hard sometimes to know. So over here you have the esophageal pressure tracing of this patient, and it's a very nice waveform, right? So you see the esophageal pressure, you see the cardiac oscillations occurring on this patient. So it's one beat, another beat, another beat, another beat. And on the lowest border, you have, in the lowest border, you have actually the airway curve plus the esophageal curve gives you the transpulmonary pressure. So remember the pressure inside, so in the airway, so pin minus pout, the pressure outside. So a given this plus this one gives you this waveform here. And the key part, I'm going to forget for now about the transpulmonary pressure because it's not relevant for the synchrony issue that we're looking at. But if, and I don't think I can put lines here. No, I cannot put a line. But you can figure that the pressure actually starts to drop right here. And if we roughly thread that up, you can see that it matches that rise on flow, that is this shaded area that I created there, with the effort, the inspiratory of the effort of the patient, and then the patient relaxes, the pressure starts becoming down, and then the pressure delivered by the ventilator goes up, and it's that the cycling of the ventilator. Actually, if we look at the next one, actually it's exactly the same, and you can see here this waveform, and it matches with what we see on the flow waveform, right? And so this breath that the machine detected as a patient trigger breath was triggered by a cardiac oscillation. A cardiac oscillation. I mean, isn't that something? That's a surprise face of an individual looking at this. And so the message is actually that this one over here is a false trigger. And so you have early trigger, you have a false trigger, which actually was in reality, it was an early trigger too, but it was triggered by the oscillation of the heart, and then a really passive breath in this patient. So really interesting. Rob, any comments?
Yeah, I want to go back to your comment about how to quantitate work shifting.
Yeah.
And we certainly don't know how much work shifting is good or bad, but this is a perfect example of how you could guesstimate, because on the right-hand side, you have a passive patient. The area under the flow curve is the tidal volume, even though you don't see it. On the first one, you have drawn the difference between the passive curve and the active excellent. So what you have shaded in there is flow due to Pmus. And the areas are roughly the same. So you could say that half of the tidal volume is due to Pmus. So work shifting is around 50%.
I love that. I love that analysis, Rob. That's great, and that's because we augmented the tidal volume by 50% of what the patient was getting. Is that correct?
That's what I'm saying.
All right. Okay. Comments from the team. Any questions, disagreements? So in summary, this is a pressure control CMB adaptive targeting with mainly elastic load, and a beautiful example of how the esophageal pressure can, what we had read was early triggering, and then one breath actually fooled us because it was actually a false trigger, leading to a early trigger on this patient. We talked about work shifting and how this one would be perhaps the quantification would be 50% of work shifting, and then finally we talked a little bit about cycling. I see a question from Chip that says, if tidal volume on the first and second breath is roughly the double of the third, but this is adaptive pressure control, why didn't the pressure drop on the third inspiration? Great question. It all depends, and Rob, please correct me here. It all depends on the algorithm that they have for the ventilator, for adaptive. Not all ventilators behave the same way. Actually, over the weekend, when we were in ARC, we saw a ventilator that you can actually program how fast does it change the pressure depending on if you're out of or within the range. So really interesting, Chip. The algorithms are not the same for every ventilator. Rob?
Exactly right. And there's no way to tell from the manual.
No way to tell from the manual. All righty. Here's another one. This is another gift from the from their group. Actually, I'm gonna go to the third one, and then we'll come back to the second one. This is also a beautiful example. So please, again, I mean, in terms of the tag, it's exactly the same tag. So it's PCCMBA. So I'm gonna give you that freebie. And now the question for you is, what is the load, and do you see any patient ventilator discordance? And don't get fooled by this first breath over here. So just ignore it. That's just the screen is refreshing. So it's not that there were two breaths one after the other. Okay, so I'm gonna just cross it so that your brain doesn't sabotage you. And again, this is a courtesy from the INER, the National Institute of Respiratory Diseases in Mexico City.
Eduardo, does P pico mean peak inspiratory pressure?
Yes, peak inspiratory pressure. The value that you see below is the exhaled minute ventilation. The next one is the exhaled tidal volume, the frequency, and that's it. We should have I'm going to change the language of all our ventilators just for kicks and giggles.
You could do it.
All righty. So good. So I'm starting to see some answers. So do you see? So I see one talking about elastic load, and I agree with the elastic load. I mean, this returns really rapidly to baseline, right? Within half a second, you have gone back to baseline. So, and the same during expiration. During expiration, probably a little bit longer, but it's pretty fast. So it's an elastic load. I think that we all agree with that. And then Ariel says there's no Pmus, and Chip Welter says, yeah, there's nothing, and there's some late cycling, and you're saying that there's late cycling, although there's no Pmus. It's just because it's going for a lump. I mean, the setting has been set to too long, the I time. So you could call it. I mean, you cannot call it late cycle because you're telling me there's no Pmus, and if there's no Pmus, then this is just a setting. So there's no exactly. Thank you, Rob. No, there cannot be a patient-ventilator interaction in absence of a patient. So the effort. But here it goes. I'm going to show you the next image, and you be the judge and tell me what do you think. Now that I have shown this, what you have is the volume waveform on the bottom, and then the volumetric CO2 that it can be measured with this ventilator. So what's the diagnosis now? Is there a patient ventilator discordance? Yeah, what interaction is there? Yes, thank you, Ariel. Absolutely, these are not ineffective inspiratory efforts. It's failed trigger in the taxonomy. We also call the ineffective or missed triggers or whatnot. So this is a beautiful waveform. I saw it, and that's why I blocked the first part, because I thought that you would be sabotaged by looking at this and taking a look at the waveforms. And one of the problems in this particular ventilator that we're being shown here is that they do not have the ability to change the gain, the amplitude in the waveforms, so you cannot really amplify and look what's happening, and that's sometimes a problem of how much you set the gain on your or the scale in your waveform, right? So Rob says, well, if you look at it, it seems to be over and sometimes crossing on top of it, but the scale, because the scale is all the way up to 75 liters per minute, may be hiding small aberrancies on the flow, and you cannot see it. And the pressure, because during PEEP, you're controlling pressure control, you're controlling the pressure during the expiratory phase. You may not see also aberrancies, although you see now now with the knowledge, you start seeing perhaps a little undulation there. But the key is here on the end-tidal CO2, and the teaching point here for the end-tidal CO2 is that you can see the expiration is the PCO2 goes to 0, so you see 0, 0, 0. Sorry, during inspiration, you're going to see 0 because there's no CO2 on the air that we're inhaling. And then when the patient exhales, it went up and it found a plateau. And then there's evidence this rapid drop is actually a inspiration this is evidence of Pmus, and then it plateaus again when the patient exhales again, and this is what the patient is exhaling. And then again, an inspiration, it plateaus, the patient exhales, and again relaxes, and then another inspiratory. So this patient is completely out of phase. It's not triggering any breath, and it's breathing in between. So essentially Pmus, if I would draw it, is occurring here, 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 and here, completely out of sync with the ventilator. And you could only detect it because the gain, and this is a call to the manufacturer of this ventilator, is they need to put this as a ability for us to change the gain and scale. But you can see clearly down here that there was evidence of Pmus in this patient during inspiration, and that is clinically relevant. Ineffective failed triggers are associated with prolonged mechanical ventilation, and so that's not a good thing to be there. I see a comment from Ariel that says BCAP, so is very sensitive to reversals in flow, and they could be observed from far away compared to the other graphs. Thank you, Ariel. Yeah, the scale also has to do with this, right? So the changes on CO2 in the scale are larger when you reverse the flow than anywhere else. Rob?
It's good.
Isn't that a super exciting waveform?
Yeah, it's really neat.
All righty. Where am I? Sorry. All righty. And here's our last waveform of the day. And I know that we started a little bit late, so we're gonna finalize with this one. This is the third waveform that they sent us. So again, what is the tag? And I'll give you the tag just for the sake of time. It's pressure control CMB S, so meaning it's set point. We set all the variables. We set the PEEP, the inspiratory pressure, the frequency, the inspiratory time. So the question for you all is, what is the load and what is the PV discordance? All right, I'm seeing very good. So the load. Let's talk a little bit about the load. During inspiration, I want you to focus on the inspiratory flow, and for whatever reason, you can see that the scale is huge. It's 150 liters per minute, and the peak flow is only to 50. So there may have been some changes in between, and the scale, the auto scale, has not adjusted. But you can see the flow between this one and this one and this one and this one and this one is, all of them are a little bit different. They are not the same. They don't, and I'll make it bigger for all of you to see. But if you notice, it doesn't end at the same height, the flow. You see how it ends at different heights, each one of the flows? So I would say that what we see here, what we're seeing is evidence of Pmus, or some amount of Pmus, because none of them finish the same. But it would be, it's hard because the scale is again in another dimension. But I would posit to say, based on what I'm seeing on the expiration, I saw that Chip, you thought that this was resistive, and it's very likely that it's also resistive. This one is probably the best example of resistive right here. It takes almost 1 and 2 seconds to get to baseline, and then you see the flow going over. So I'm not entirely clear about the if there's Pmus or there's resistive. I cannot read it very well, and I'm open to anybody input. And then all of you recognize these aberrancies here, which are very clear, right? You see the drop in pressure and the increasing flow, which is consistent with failed failed triggers again. And so failed triggers all over the place on these breaths. During inspiration, I would call it normal. There's minimal, if anything, aberrancy of this inspiratory. And then during cycle, it seems to be appropriate, although you can see how the flow is different for each one of them, but I'm going to call it relatively normal because I don't see very well the Pmus, and I'm going to call this normal. So let me show you the reality. So again, you have down here the esophageal pressure, and you can notice the negative deflection of the esophageal pressure. And so if you remember, the pressure in minus the pressure out, so it's negative, is this pressure minus this pressure makes a positive, and that's why you see a little bump here on the transpulmonary pressure. But you can see the presence of Pmus occurring throughout and out of sync, actually, with the ventilator. And some of them are strong enough, actually, to cross the flow above the baseline. I mean, it's really above each one of them should have triggered a breath, and actually drop the pressure below the set PEEP, which tells me that probably the trigger sensitivity was set too high, or the threshold was too high for what it could have triggered. And sometimes we see that when it's triggering too fast, and they think that this is auto triggering as the cause. So, Rob, comment?
I wrote my comments in the chat, but I just said the same thing as you. It's a sensitivity issue.
Yeah, so you have to set it below auto trigger level, so the level where you don't trigger. And in this case, it's clearly at a higher level than that, right? So that it's not the patient is having only mandatory breaths, and the rhythm is completely hidden underneath. Really interesting. All right. Any other comments, Rob?
No, sir.
All right. Well, this was a very juicy. Thank you very much to the Instituto Nacional de Enfermedades Respiratorias for lending us these 3 beautiful images. Keep sending them our way. These are highly educational. And when you have these 2 signals, then you can learn to read the flow waveform and then look at the another signal that will help you confirm what you're seeing or not. I hope that you all have a good week, and I'll see you in a couple of weeks to review more images. Thank you, Rob. Thank you, everybody. Good to see you, Chip. Take it easy. Bye-bye.